Hello, everyone. My name is Sonia Rupani. I'm a physician assistant, and today we're going to be talking about measles. I have no disclosures, and my disclaimer, and the lecture objectives. So we'll start off talking about measles virus. The measles virus is also called rubella, not rubella. So rubella is the 3-day German measles. Rubella is our measles virus. They're two different viruses coming from two different families. The rubella virus, the measles virus, is sometimes referred to as the 10-day measles. Some call it the red measles, but this comes from the family Paramyxoviridae. Some of the viruses that come from this family are the pneumovirus, genus pneumovirus, and we have RSV. We have the paramyxovirus, so mumps, and the para-influenza virus, and then morbillovirus, which is measles, rubella. The measles virus has it's a single-stranded RNA. It has an envelope of lipid envelope, and it has multiple proteins on it. The measles virus is referred to as a negative sense RNA. So what that means is that for this virus to replicate and make its own protein, it has to first become a positive sense RNA using the RNA polymerase. Only then it will be able to multiply and make its own protein. Unlike other viruses that are positive sense, like the SARS-CoV is a positive sense, the hepatitis C virus is a positive sense. They do not need this extra step. Some other negative sense viruses would be Ebola virus, the hantavirus. All of these are negative sense. So there's this additional step that they have to take, their virus has to take to be able to replicate and make its own protein. So if you look at this image here on the left, this is a 3D representation of the virus. And we see all these studs. Okay, we're going to talk about two specific proteins here. The maroon one is the H protein, the heme agglutinin, and then the gray one is the fusion protein, F protein. Now, when this virus comes in contact with the host cell, it uses the heme agglutinin protein, the H protein here, the maroon one, to attach itself to the host cell. And then the gray protein helps the F protein, the fusion protein, will help it fuse to the target receptor cell, and then will allow it to penetrate into the cell, the host cell, and then start its process where it will first become the positive sense RNA. And then once it's become the positive sense, it can start replicating and making its protein and send out the virus so that there's an infection. We learned about measles back the first time back in 9th century. There was a Persian doctor, Dr. Zakaria Razi, who had first described measles in his book called The Book of Smallpox and Measles. And when he described measles, he made this statement, and I quote, "More to be dreaded than smallpox." Then, end of quote. Then later, in 1757, there was a physician in Scotland who was the first to was able to identify the virus, the infectious agent that was causing this disease in multiple patients. So he was able to identify the pathogen in the blood of patients. Back then, we had no vaccine, and there were about 3 to 4 million cases of measles infection in United States every year. More than 40,000 individuals who were infected would be hospitalized. There were many people who were dying, like 400 to 500 deaths a year because of measles. And many were suffering complications, including, 1,000 cases of encephalitis because of measles. So 1912, measles was made a nationally notifiable disease in United States, and it is yet a notifiable disease. As we're talking about all these, number of cases that we were seeing, we had no vaccine. So Dr. Thomas and Dr. Enders, with their group, they came together and they decided to develop a vaccine to help prevent this very serious, very highly contagious disease. So there was an outbreak in our school in Boston, Massachusetts. So they started collecting blood specimen from these children who were severely ill with measles infection with the hope that they can develop a vaccine. And then in 1963, they were able to develop a vaccine, and that vaccine was licensed in the United States. Later, 5 years later, we had Dr. Morris Holman, who is our American biomedical researcher. He and his group came up with much more improved and even weaker measles vaccine, which then got introduced in 1968. Dr. Morris Holman, he has contributed to many vaccines, I think around 40 vaccines, like their chickenpox vaccine and hepatitis B vaccine, their MCV meningococcal vaccine, and many more. So all these doctors and all these people were coming together to come up with a vaccine to help prevent this very serious disease. So 10 years from the time that the vaccine was made, CDC came up and said, now that we have a vaccine that can prevent this very contagious and very serious condition, we need to set a goal. So they set a goal saying that we need to eliminate measles by 1982. Then in 1982, we had not met that goal. However, there were 80% less cases of measles in the United States. Later, in 1989, there was a huge outbreak again, where it was seen in school-age children, and these children were vaccinated. They had received their measles vaccine. So the ACIP, the American Academy of Physicians, the American Academy of Pediatrics, they all came together and looked at the effectiveness of the vaccine. And they said, hey, if we're giving one dose, then the vaccine is 93% effective. If you're using 2 doses, it is 97% effective, which means, if there were 100 people, it's going to protect 97 people, right? So then their new recommendations came as, all right, we're going to now do 2 doses of their measles vaccine. So that came in 1989, and even today we do 2 doses of measles vaccine. Later, in 2000, we finally reached that mark where there were not a single case. There was no case of measles the entire year. So 12 consecutive months, there was no transmission of measles in the United States, and the public health officials made a declaration that, yes, we've eliminated measles from the United States. So that was like our great thing. If you look at this graph here, this is coming from CDC. These were cases that were reported in United States, 1962 to 2023. However, the graph cuts off at 2020 here. You see the number of cases. So see how we were at like the peak. Then after a vaccine was introduced, there was a drop. And then in 1980, we see around here that second dose was introduced because of that outbreak in school-age children, and then no cases at all. And then elimination of measles was declared. Before the vaccine was available, if we look at the global mortality, measles was causing about 2.6 million deaths each year globally. Now that we have this very safe, effective vaccine that can prevent this disease, we are yet seeing about 100,000 deaths a year globally. So this is coming again from CDC. In 2023, so not too long ago, we saw 107,000 deaths because of measles, and most of them were children. Now, if we look at the cases of measles in the United States, we see, and I've gone from 2019 down. So in 2019, there were about 1,200 cases of measles, which was the highest that we had seen since 1989 when the recommendation of 2-dose vaccine came in. So there was this high number of cases in the United States, and most of those that were infected had not been vaccinated. So it was seen more commonly among those who were not protected. Then in 2020, there was a drop. We had 30 cases. 2021, 49 cases. So we've been fluctuating. It's going up and down. And then in 2022, 121 cases. And, if we recall, this was the time where, 2020, 2022 was the time where we had the COVID pandemic. And that had disrupted medical care. Patients were not able to get their vaccines as children were behind on their routine standard vaccines. And this was not just in the United States. We were seeing this all across the globe. And if you see back in 2022, there were 136,000 deaths because of measles globally, and most were in children again. In 2023, we had 59 cases of measles recorded. And then in 2024, so last year, we had 284. This is as of December 31st, 2024. 284 cases were reported by 32 jurisdictions, and multiple states listed here, like state here too, Tennessee. So when we look deeper as what was the distribution. We see that out of their 284, 42% were children under the age of 5. And then if you look at the vaccine status, 89% of those who were infected, those cases that were reported, were either not vaccinated, so they were unvaccinated, or had an unknown vaccine status. So once again, we have a vaccine that prevents this disease, but there's been a gap, and we're seeing cases of our measles. Measles is highly contagious. It's one of the most contagious infections that is known. So if you look at the R naught, so that R0 is referred to as R naught value for measles, which just means that, our R naught is how many cases of a disease can you see from one single case. So if one was infected, how many more can that person infect? So the R naught for measles is 12 to 16 in unvaccinated population. So just to give a reference, if you were looking at the R naught for seasonal flu, which again varies from year to year, but is typically in that range 1 to 3. With COVID-19, it was in the range 7, 8, around there. But with measles, we are seeing the R naught is 12 to 16. So it's very contagious. And so if there were 10 people, and there was one person who was infected, it will infect 9 people if they were not protected. If they're not vaccinated, it can spread to those 9 people. So it's highly, highly contagious disease. Measles is transmitted person to person. So it's airborne, and it will spread through respiratory droplets. So say if the person has measles, when they cough, they're sneezing. Now all those tiny respiratory droplets are out, and it will stay. It travels, and the virus stays alive. It's living for up to 2 hours. So which means if the person has coughed or sneezed and they walked away, and the person who was coughing is gone. However, that virus is yet living. That virus is yet can infect others. So say if there was another person who walks by and is now exposed to that virus that yet can cause the disease, and if they're not vaccinated, then they are highly likely to get that disease. Also, infected surfaces. It can live on infected surfaces. So for up to 2 hours. So again, if there's an infected surface, so if the person had coughed, sneezed, and then had touched something, and there's somebody who is not vaccinated, who's not protected, is now coming after them and is touching their eyes, their nose, their mouth, now they can get infected as well. So with measles, we spoke about those two proteins, the H protein and the F protein. Once the virus is a person who's is exposed, and if they are not vaccinated, they're not protected. Once they're exposed, this virus will go ahead and attach to the respiratory mucosa, the epithelial cells, and then get into the system and then start replicating. Most cases, first the nasopharyngeal and conjunctival mucosa, where they start replicating. So now the patient is having their respiratory symptoms. Then it starts spreading to local tissue, the lymph nodes, and then it becomes more systemic. It's in the bloodstream. So it's also been found that measles can affect our immune system. And this immunosuppression can last for up to 6 weeks. There's a hypothesis that the measles can cause immune amnesia. That means where you were saying like it'll replace our memory cells by the measles specific T lymphocytes. So now all those memory cells that our body has made after being exposed to different things are now erased. They're lost. There's amnesia, and now that makes the person most susceptible to secondary infections. So that's a hypothesis. It's called immune amnesia. But measles, we know that measles can suppress our immune response. When we look at who's at risk, again, unvaccinated individuals. So those who are not protected, unvaccinated infants. So we know our vaccines are begin at 12 months for measles, mumps, rubella. So those infants are at risk, because even if they have got the antibodies from their mother, so the mother has been vaccinated, now those antibodies can be transferred to the fetus. the infant will have the antibodies, but then they start, well, fading off and they will wane and they may not be protected. So they are at risk. Pregnant women, immunocompromised individuals. So people, HIV, somebody on chemotherapy, somebody taking medications that are immunosuppressants. All of these individuals are at risk of getting the infection. Also, exposure, right? Especially when you're not vaccinated and if you're being exposed to or you're traveling to areas that are endemic, where measles is endemic, then the likelihood is much higher that you would get the measles infection. So when we look at clinical stages of measles, we can divide that into four. There's the incubation period, there's the prodromal, the exanthem, and then the final stage is the recovery and immunity. So if you look at this child here, the child has a rash that we see, which means that they are in the exanthem phase. And we see that it's on their forehead, it's covering the entire face, and it's maculopapular rash. So you see it's all over the face. So we'll go and look at each of those stages. So incubation period is the time that the person is exposed to the virus to the time where they first experience a symptom. Okay, and the incubation period for measles is 11 to 12 days, which means if they're infected, if they are asymptomatic, they are unaware that they're infected, and they are going to work, they're going to school, they're doing everything, they're out there in the public because they don't know, right? So this incubation period can be as long as 11 to 12 days. Then after the incubation period comes the prodromal stage, which is where the patient is now going to start having symptoms. And the initial symptoms that we see with measles is very high fever. And the fever can be as high as 104 or 105, so real high fever. They're tired, they're irritable, especially children. They are very irritable, they are refusing food, so loss of appetite, anorexia. And that's when we see the 3Cs. That's classic for the measles. The 3Cs, the coryza, conjunctivitis, and cough. So coryza is just rhinitis. So now the nasal mucosa is inflamed. Conjunctivitis, the conjunctiva is inflamed and it's red and injected, and then cough, which is a symptom that persists even after the patient, the rash clears up, the fever's gone, there's clinical improvement overall. The rash persists for about 2 weeks in most patients. So during this stage, we also, because they have congestion, they have all this runny nose, they're sneezing, they're coughing. Sometimes it may be tricky as like, that's all they have. They have a high fever and they are irritable and they have this stuffy nose and they are coughing and they have drainage going down. The patient may be complaining of like, I just have a sore throat, or they are having tonsillitis, or sometimes even exudative tonsillitis is seen. And in some cases, even splenomegaly is seen with measles. During this prodromal stage, we also see enanthem, the Koplik spot. Now, Koplik spots are pathognomic, which means we only see these with measles. So if we see these in our patient, that's a giveaway that this is measles, especially if your clinical presentation and the history is all supporting the diagnosis. So with Koplik spots, these are commonly described as white grains or salt grains on a red background. And that's because they appear very tiny. They're like 1 to 3 mm, small, tiny white spots. And that those white spots are because their cells are destroyed there. So they appear pale. So they're white. And sometimes, they may look a little bluish around because of their venous engorgement in that area. So these happen, we see this most commonly on the across from the molars in the buccal mucosa. So that's most common site. And these are seen, once they are seen, 48 hours later, the patient will have the rash. So that's the typical pattern with Koplik spots. So if you see over here, these are the Koplik spots, the white spots that we're seeing. Okay. So when is the patient infectious? So before going into the next phase, when is this patient infectious? The rule of 4, okay? Patient is contagious, they're infectious 4 days before the rash and 4 days after the rash onset. So if the prodromal phase typically will last like 3 to 4 days, right? And now, which means that the patient it could be infectious the last day of that incubation phase, and then the prodromal phase, and now 4 days after the onset of the rash. So the rule of 4 is a good way to remember that when is the patient most infectious. So if you look over here, this baby also, it looks like the baby's congested, and now they also have this rash. And we can see the rash over the forehead, the face, on the upper extremity, the trunk. It's all generalized rash. So with the next stage, the exanthem stage, which is seen, 2 to 4 days after the prodromal phase, this is when the patient has the rash. Okay, and the rash is sometimes described as brick red, so it's bright red color, and it's maculopapular. So some lesions may be a little raised, some may be flat, but over time they kind of become more confluent, giving that blotchy look. They're blanching, and very rare will patient complain of itching. Very rare. If they have the itching, it's pretty mild. It's not typical to have pruritus with measles rash. So if you see over here, this child has the measles rash and we see maculopapular lesions, the hairline, the forehead, it's on the side of the face. See, some lesions are looking more raised, and then this is all confluent and more, looking blotchy. And you see it all over here on the cheeks, on both sides. The measles rash, the typical way it spreads is the cephalocaudal, which means it starts on the head and then goes down. So we see the rash typically beginning on the face, their hairline, behind their earlobes, goes down then to the neck, and then the trunk and our extremities. So the upper extremities and the lower extremities also affected. So it's a generalized rash. So once again, this child also has this maculopapular rash, and we see how it's covering their forehead and a few lesions here on the temple area as well. So as we said, the rash spreads to the neck, the trunk, and over here we see that the rash is on their scene. It's pretty diffuse here on their lower extremity bilaterally. I put this image, this is because, yes, we see this more in our children, younger than 5, especially if they're not vaccinated, but measles can happen to anybody. If they're not protected, they're not vaccinated, it can happen to anyone. So wanted to show this image. This is our image of this person when in the prodromal phase. So if you see, the face looks kind of shiny, probably has a fever. You can see a little redness to that eye, and then you see over here, this is the exanthem phase where now this person, it's the same person, has this maculopapular rash and looks like, he's not comfortable because even during that rash, when they have the rash, they have very high fevers. And during that prodromal to that exanthem phase, their symptoms peak like 2 to 4 days, and they have very high fever and that rash. So just wanted to show that rash on an adult as well. So as the rash will persist for 4 to 5 to at the most 6 days, typically, and then it starts eventually fading off. And as it fades off, especially if the person has a lighter skin color, they may see the color become more darker. So it may look brown, copper color, and gradually it fades off. In some cases, we may start seeing also desquamation, especially if the rash was very dense and confluent in that area, then slowing of the skin is also seen. So again, letting the parent and caregiver know, because it could be alarming for some, is like, oh, why is the skin peeling off? Overall, that we start seeing in, the improvement and the cough, as I mentioned before, the cough is one symptom that persists for about a week to 2 weeks in most patients. Then comes the final phase, the recovery and immunity. Once a person has been infected, they develop the lifelong immunity after the infection. It's very, very rare to have a reinfection. Now, those cases, I was looking at different cases in literature, and those that I was able to find were in the very severely immunocompromised. But in general, once there is the post-natural infection, measles infection, there's natural immunity, and that immunity is lifelong. This patient here, this little boy here, this is a picture coming from a camp, a Nigerian refugee camp where there was an outbreak in the 1960s, 1970s. And here we see that there is this measles rash, but now the slowing of the skin almost looks like it is burned. But this child has this generalized rash, and now it's kind of slowing off, so it's fading off now. So with measles, we said, how we have these different stages and that it can suppress our immune response. Measles is linked to many complications. Okay, it's not just the rash, not just the cough, congestion, and coryza. It's linked to many complications. Pneumonia, measles pneumonia is one of the most common one. Diarrhea, secondary infections like otitis media. So it is not only the rash and the upper respiratory symptoms and conjunctivitis, it's more than that. There's a lot of complications linked to measles that could, in some cases, be fatal. So with measles pneumonia, it is one of the most common cause of measles-associated death in children. And most cases are more serious and cause more complications, especially when the child is less than 5 and older than 20. That's how we've seen. And then, these patients, other than having the measles pneumonia, these patients are also at risk of secondary bacterial pneumonia. And most common pathogens are strep pneumoniae, the strep pyogenes, staph aureus, Haemophilus influenza, and they can also be a co-infection with like a virus, adenovirus, the RSV, the influenza virus, making it even more difficult. If we were to do a biopsy of the lung tissue, we would see what's called the multinucleated giant cell as seen here. So these are all the lymphocytes, and this is the multinucleated giant cell, which is referred to as the Warthin-Winkle-Day cells. So they're just giant cells, multinucleated giant cells that are commonly seen with measles pneumonia. Some GI complications we see, we spoke about diarrhea. About 8% of the cases will have diarrhea. Now imagine if a child, and we said more cases are seen in children, if a child has diarrhea and they also have gingivitis, this is another complication we see. Now they cannot eat, they cannot read or drink. That leads to, dehydration and increases more, makes recovery more challenging. I mean, especially in places where there's not enough resources. Like, we can imagine how difficult it would be if the patient has diarrhea and gingivitis and so on. Some other GI complications that are linked to measles, hepatitis. They can have appendicitis, and then the lymph nodes in the mesentery would be inflamed, so causing the mesenteric lymphadenitis. As seen here, this image shows, the lymph nodes are enlarged, and we know that most cases will mimic, because it mimics the appendicitis because it's in the right lower quadrant. Immune suppression, we said that the immune response can be suppressed for up to 6 weeks. And most of these patients, one of the most common secondary infection we see after measles is the otitis media. So patients can have otitis media. Sometimes the otitis media can lead, can get severe enough to cause conductive hearing loss. In some cases, even sensory neural hearing loss, and leave the patient with a hearing impairment. Patients can have bacterial pneumonia, again, the same common pathogens, strep pneumonia, staph aureus, the Haemophilus influenza. So now they can also have a secondary infection with bacteria. They can have bacteremia. So a lot of secondary infections are seen, but these are the common ones. This is our picture showing the otitis media, and there's also the bullous laryngitis. Measles can also cause some neurological conditions and complications like encephalitis. This is seen 1 in every 1,000 cases, and typically seen within the first few days of the rash. And it can happen anytime between 1 to 14 days, but typically we see on the day 5 that the patient may start having encephalitis, and symptoms that they present with will be like their signs of meningeal irritation. So they have very high fever, photophobia, nausea, vomiting, stiff neck, nuclear rigidity. All of these are seen along with seizures and coma. Now, 25% of the survivors, 25% of the cases after measles encephalitis can have neurodevelopmental sequelae, and the mortality is high, 10 to 20%. This is a case of acute measles encephalitis in a patient. She was a 28-year-old immunocompromised patient. So again, it can happen to anybody. It's not just children. It can happen to any age group, especially individuals who are at risk, immunocompromised, unvaccinated. And So if you look at the MRI images here, these images were taken at the same brain level. So you have these three, and they were taken at different timings. This A through J first week, B through K the second week, and then C through L fifth week. And we see that look at these white spots. There's cortical hyperintensity seen in the first week. If you go into the second week, you can see how that's spread, and then it's, almost covering all the areas are being covered. By fifth week, we're seeing that it covers, like we can see the thalamus, the putamen, the globus, all of this is covered. So it's widespread hyperintensity of the cortical hyperintensity just suggests that there's inflammation, and that's because of the measles encephalitis. The patient did not have a very good outcome. It was a very poor prognosis. Another complication, neurological complication, is the acute disseminated encephalomyelitis, ADEM. This is also 1 per 1,000 cases of measles. It's a demyelinating condition and typically seen within the 2 weeks of the exanthem. So once the patient has the rash, 2 weeks later, they can develop the ADEM. Mortality is 10 to 20%, and these patients will come in with their signs of meningeal irritation. So they have high fever, nausea, vomiting, photophobia, stiff neck, and they will also have ataxia, chorioathetosis. They may have the signs of myelitis, so they may have paraplegia, quadriplegia, and again, patients who are survivors of the ADM, they can have cognitive deficits, epilepsy, and behavioral disorder. So again, if you see over here, this is ADM seen in a patient, and you see multiple lesions all across. So corneal or ocular complications seen with measles, we don't see that many here in the United States, but I was looking at cases outside internationally, and there are so many cases where patients had measles and then became blind and permanently blind. So keratitis is one of the common reasons why patients are blind, and this is permanent vision loss, and this because of measles, that we have a vaccine to prevent it. But corneal ulceration and keratitis are complications of measles. Cardiac complications seen, again, more literature, more studies done in internationally, because there are more cases there, and most cases showed that patients were presenting with measles, post-measles, with myocarditis or pericarditis. Again, this child just has this, we're seeing he's in the exanthem phase. We can see the rash on the face and their forehead and some on the neck. So those were some complications we discussed that were happening, within 2 weeks, a few days after the rash. But there's another complication that's a long-term complication that is seen after 7 to 10 years after the rash, the measles infection. So this is the subacute sclerosing panencephalitis, SSPE. It's very rare. It's 1 in every 5,000 reported cases that they will have the SSPE. However, their mortality is very high. It is a progressive degenerative condition, and more patients who are at risk are those who develop the measles infection, who get the measles infection very early in age. Their disease is divided into 4 stages, where first stage patients may have just behavioral changes and personality changes, and that can last for months to years. And then stage 2 is where they start having myoclonus. So they're having this very severe, irregular, sporadic jerking of their different body parts. And then stage 3, that myoclonus will disappear, and then they have weakness in their muscles. They have hypotonia, and then finally stage 4, that becomes where it's decortate in, and it becomes a vegetative state. And most patients die by the time they reach stage 4, but that could happen anytime between stage 1 to 4. So it's very, very serious. It's progressive degenerative disease. And again, over here, we can see the cortical atrophy in this patient. So this is a early stage and a later stage imaging finding. So we said that patients come in with fever, upper respiratory symptoms, they have the congestion, they have their conjunctivitis, they have the cough, and then they have the rash. And if we are seeing that the three C's, the fever, and we are seeing, or we are hearing their history, and they have this rash that's maculopapular, and we're hearing from them that our patient that they have traveled and they're not vaccinated, or they've been exposed to somebody who had a febrile rash illness, then or we need to take it, consider measles, because it could be measles that we're dealing with. And if we think it is measles, we need to start taking action. We need to provide our patient with a mask. Anybody around or their family members need to be also given a mask, and then we have to isolate the patient and that family in a separate room. Preferred if there is a airborne infection isolation room available, then that would be great. If not, then a separate room and patients should be asked to keep the mask on. There are providers, and all those who are attending to the patient must be wearing an N95 and should have immunity. Only those people should be working closely with the patient. Also, we need to follow our, obviously our institutional protocols, but then we need to call our local and state health department and notify the CDC, and then that way they can help us give us further guidance. And if you click that link, it is like our whole guidance of what needs to be done step by step. If you've called the CDC, I've done that before, that it's wonderful because there's always somebody who's an expert on the other end who can guide and instruct as like what you're supposed to do. I had not called for measles. It was some other case that our clinic had to get more instructions for, and it was wonderful service, so quick, easy to get in touch with them, and they gave us good guidance as like what we were supposed to do. So use their number. So we need to contact our health state department, notify their both suspected cases and confirmed cases, need to inform CDC, and then use the CDC helpline in their local health department so that we can get the assistance we need if there's any questions about the condition, especially because this is not that common here in the United States. So some differential diagnosis, again, it could be Kawasaki disease. The patient has a fever, and they said the fever could be very high, 104, 105. They have a rash. They have the conjunctivitis. That's seen in Kawasaki as well. It could be meningitis, high fever, child is irritable, they've got a rash. So parvovirus, the fifth disease, the human herpes virus, 6, roseola. It could be hand-foot-mouth disease, scarlet fever. Again, that causes the rash. They could have their pharyngitis. So the differential list could be long. But if we suspect based on their history presentation, then we need to take it seriously and take action. With diagnostic evaluation, our initial diagnosis comes as a clinical diagnosis based on our history, our physical exam. But when we're trying to confirm the diagnosis, the preferred testing is going to be the PCR. And nasopharyngeal swabs, oropharyngeal swabs are preferred. In some cases, urine specimens have also been used to test to do the PCR for testing for measles. And then the serology tests for measles, IgM and IgG. With the IgM, with our humoral immunity, we can see the IgM antibodies. They become detectable 3 to 4 days after the rash appears, and then can persist for up 4 to 6 weeks. And then later, the patient will develop the IgG antibodies. A little bit about the VFC program. This is the Vaccine for Children program that was developed back in 1994. So if you recall, we spoke about how there was resurgence of the measles in US. 55,000 cases had been reported. There were more than 11,000 people being admitted. About 166 people had died, and it was because they suspected it was because of the measles. So US Congress came together and said, we have a vaccine, it is safe, it is effective, and we need to protect everybody. So the program was established to make sure that everybody gets the vaccine, even if they don't have the insurance and they cannot afford the vaccine. So with that said, we have our vaccine schedule. It's a 2-dose series, and the first dose is given, the first dose of MMR vaccine is given at 12 months to 15 months, so after they have their first birthday. And then the second dose comes at 4 to 6 years, and most parents and caregivers will say, they've got their first dose now, so next dose will be kindergarten. It's like, yeah, that's their timing. We also have the combination vaccine, measles, mumps, rubella, varicella combination vaccine. Now that could be given. It's approved if their patients and if the parents and their caregivers prefer that, then that can be also used instead. So catch-up vaccine. So say if there's a child who was never vaccinated, or they got their first dose and then never came back to get the second dose, or it's an adult who has not been vaccinated or does not have evidence of immunity, then they would need the two-dose series at least 4 weeks apart, so 28 days minimum. So 4 weeks apart, you give them their two doses. If their MMVR can only be used up to the age of 12, it's only approved for up to age 12. So if we are giving it to our older children or the adolescents and adults, it's going to be the MMR vaccine. Also, their vaccine is live vaccine, so it cannot be given to pregnant women, or other contraindications will be if they have an allergic reaction to the first dose or have an allergic reaction to a known component of any of the ingredients of the vaccine, or if they're pregnant, or immunocompromised. So those are some common contraindications for the vaccine. But otherwise, their recommendations are the two doses, at least 4 weeks apart, if we're doing a catch-up. Herd immunity. So we need about at least 95% or higher herd immunity. So by giving two doses of the measles, mumps, rubella, or the measles vaccine. And what that means is if we had more than 95% or higher number of people who are vaccinated, then it'll be difficult for having outbreaks in their community, because now most of them are protected. So it will be difficult for spreading the disease in the community. So, we always aim for herd immunity to help protect the communities, to help protect the children, and achieve and maintain that measles elimination status that we earned back in 2000. If we look at the US vaccine status, especially the kindergarten, we just mentioned kindergarten as first dose at 12 months to the 15 months, and then the second dose at kindergarten. We have seen a decline in their kindergarten coverage. So if you see 2019 to 2020, the rate was at 95%, and then in 2023, 2024, there's been a drop to 92%. And, during that COVID-19 pandemic, there was many children had missed their vaccine. So again, we need to bring them back on track, make sure we are reminding the parents, caregivers that if their child did not get the vaccine, we're updating them with the vaccine. If there's any questions about or hesitancy, we make sure we are clearing those misconceptions and making sure that everybody stays protected. With vaccine coverage, there was a study, and the references down there. There was a study that was done that was looking at the vaccination status among children who were born between 2020 and 2021. And when they did that study, they found that the vaccine coverage was much lower in the non-Hispanic Black American population, Hispanic Latino population, the Hispanic American, and the non-Hispanic American Indian natives, and when they compared that to the non-Hispanic white population. Also, the coverage was lower among the uninsured children who were covered by Medicaid or some other non-private insurance when compared to solely by or private insurance. It was also lower among children who were below the federal poverty line as compared to those who were living at or above the poverty line. So there was these gaps that were identified in that study. So how do we fill those gaps? How do we make sure that we continue to protect everybody? So one strategy would be to increase awareness. We need to bring this, get this information out. We need to increase awareness by talking about the vaccine, its importance, and what the disease can cause, what this infection can do, the complications it can cause. Review their child's history and recommend their vaccine every encounter. So sometimes just reminding the caregiver and the parent will help. Is you missed this vaccine. We need to schedule an appointment and get you back in so we can keep the child protected. Addressing financial barriers. Now, there are times where patients may not know, their parents may not know that there's the VFC program, there's Medicaid, and other programs. If they don't have insurance, the vaccines can be covered under those and they can have access to healthcare. So talking about, addressing those financial barriers with our parents, patients, and caregivers. Addressing vaccine hesitancy and misinformation. So we know back 1988, there was that article that was published that caused the misconception of MMR with autism, right? That was then retracted. And then there were several studies that have been done since that have proved that this was not true and the vaccine is safe. So sometimes just talking, and we saw that decline of vaccine status around that COVID pandemic. So again, talking to patients about what the vaccine is, how long it has been around, how it's protected people, how it saves lives, how it can save us from complications, and so on, can help improve our patients' confidence, the parents' confidence about the vaccine, and then reduce those hesitancy. Also, having a reminder recall system. So just some have their portal where they can send the message across, and it's an automatic message that the portal sends as like, hey, it's time to get the vaccine. Your child is this age now, reaching the first year mark, or is 4 years. It's time to get the vaccine, and so on. Those frequent reminders can also help get those people in so that we can vaccinate everybody and protect the community and those patients. Also identify communities with suboptimal vaccine coverage. So if they're not getting the vaccine in certain areas, increasing the access and help, access to care in every area so everybody gets the protection they deserve. With that said, we'll just summarize what we've learned. One, that measles is a highly contagious condition. It's a highly contagious infection with the R naught of 12 to 16. It is caused by the morbilliform virus coming from the Paramyxoviridae family. It is the rubella virus, not the rubella. And then it is a negative sense RNA that converts to positive sense and has these special proteins, the H protein and F protein, that help it bind to the host cells and then cause the infection. The infection is transmitted from one to the other. It's airborne and through infected particle surfaces, and those viruses can stay alive for up to 2 hours. Incubation period, prodromal, exanthem, recovery, immunity are the 4 stages. Incubation period is where they're asymptomatic, but they have been infected. Prodromal phase, where we start seeing that they come in with fever, they have their, anorexia, they're tired, they're irritable, and then they have the 3 C's, the coryza, cough, and conjunctivitis. They then later, in that phase, in that same prodromal phase, they may have the Koplik spots that are seen typically on the inside of the mouth. So the buccal mucosa opposite of the first molar, and it's pathognomic for measles. And then 2 to 4 days later, they have their rash, and that rash is their exanthem phase. And the rash is maculopapular. It's bright red, called a brick red rash. It spreads from the face, head down, and becomes more generalized. It's blotchy because it becomes more confluent. The rash and during that period, the patient may have very high fevers, and the rash can last up to 5-6 days, and then it gradually starts fading off. And then there's slowing of the skin, and there's clinical improvement. The cough can persist up to 2 weeks. The recovery phase is where now after this infection, they build the immunity, and it's a lifelong immunity in most cases. It's rare to have a reinfection. Remember that the rule of 4, patients are infectious 4 days before the rash and 4 days after the rash. And that the rash is not just a rash and upper respiratory symptoms. It is linked with many complications and that can increase morbidity and mortality in people who are infected. It can cause the measles pneumonia. It can cause diarrhea, secondary infections like bacterial pneumonia, bacteremia, and otitis media, which can cause hearing impairment in many patients. It can cause encephalitis, where the mortality is very high, the acute disseminated encephalomyelitis, keratitis, which can cause blindness, that's permanent vision loss, myocarditis, pericarditis, and in some cases, 7 to 10 years later, even after it's been that long period, it can cause the subacute sclerosing panencephalitis, which is very deadly. It's a progressive degenerative disease of the CNS. All patients, we need to know our patients who are at risk, those who are unvaccinated, individuals of any age group, infants, because they've not received their vaccine. Their first vaccine is going to be at 12 months. Immunocompromised individuals, the pregnant women, all of these are at risk. We need to, when we suspect the measles case and we need to start acting, they need to be given a mask. They need to be their patient needs to be isolated. Preferred is the AIR room, if available, if not in a separate room. And also, once we put them in that room and they've been transported, then that room should not be used for up to 2 hours so that we can wait, because we know that the virus can live for up to 2 hours. The providers and everybody, all the healthcare workers need to, only those who have evidence of immunity, a confirmed immunity, should be the ones who should be working and attending to the patient, and they should be wearing an N95 mask. We need to contact our health department, the local state health department, and CDC. Also, when it comes to diagnosis, it is a clinical diagnosis that is then confirmed with PCR, nasopharyngeal, oropharyngeal swabs are preferred. And then the serology IgM antibodies that are typically seen, 3 to 4 days after the rash and can last up to 6 to 8 weeks. And then the IgG antibodies will be developed later. We have our MMR vaccine and then the MMRV vaccine. If the parents and the caregivers prefer, that vaccine is available as well. The first dose of the MMR vaccine the measles vaccine is given at the age of 12 months. Then the repeat dose, the second dose comes in at the age of 4 to 6 years. And the catch-up vaccine, again, if you're using the MMRV vaccine, and we can use it if they're less than 12 years. And if we're doing that vaccine, there should be a gap of 3 months, or if we're doing a catch-up vaccine. But otherwise, we could use the MMR vaccine, and for that, the doses are separated by 4 weeks. Okay. We should remember our contraindications for the vaccine because it's a live vaccine, and that once we have vaccination coverage, if the patients, and immunization strategies in place, we can get closer and we will be able to maintain the elimination status that that United States had earned 2000, and can also help reduce the morbidity and mortality in our patients. I appreciate your attention. Thank you very much. And these are my references. Thank you.